In just about 15 minutes, we are going to hear from someone who is regularly at the core of addressing progress here in California, President and CEO of the California Health Endowment, Dr. Robert Ross, who will share with us how the empowerment and engagement of women is crucial to making California's communities healthier. While we have a few moments before he speaks, I want to challenge you to think about your own work and your own role in improving women's lives. We've provided some question cards for you, and I hope you'll take the opportunity to ask Dr. Ross about his work and engage in this dialogue.
I'm Marilyn Summers. I'm the director of the Penn Center for Global Women's Health. And I hope you've been as informed as I have and as energized as I have by all of the speakers who have shared their knowledge and experience with us today. I also hope that you're enjoying your lunch, but a bit quietly, if you can, so that you will be able to hear our next speaker. Before introducing our speaker, I'd like to talk a little bit about the Center for Global Women's Health and the impact that we're trying to make on women around the world, and particularly with many of the issues that we talked about today. There are many projects among the faculty who work at the Penn Center for Global Women's Health to try to do some of the very constructive interventions that we spoke about. The center was officially launched in 2011 at our Healthy Cities, Healthy Women event in New York City. The center is an interdisciplinary group of faculty members and students. We have a training program as part of the center for both predoctoral students and postdoctoral students, and many of our undergraduates at Penn are also involved in the center activities and the faculty research initiatives. The center serves as a focal point for the generation and translation of research that promotes the health of women and girls across the United States and around the globe. And we have three major focus areas that we concentrate our efforts in: safety from violence and harm, and you heard from one of our faculty members, Ann Titleman, today about her work in that area; equity, empowerment, and advocacy; and health promotion and disease prevention. So our scholars work toward these goals to recognize that as the health of women goes, so goes the health of the world. Over the past year and a half, our center has established itself as a leading research center at Penn and an important source of scholarship in the field of global women's health. We're developing coursework in the area of global women's health and hope to have a postdoctoral course in global women's health shortly. We plan to pursue a number of research projects that will have health both at the local area and internationally. And a few of these examples of the scholarship, the faculty at the Center for Global Women's Health have been working with a clinic in the Halkidiki area of Greece, which is northern Greece. This is a really important area for a number of reasons. First of all, I know that you're all aware of the significant economic difficulties that Greece is having right now. The economic difficulties are as such that there are many women who can't even get federally funded pap smears. So we're looking at other mechanisms to have cervical cancer screening in northern Greece. If you know anything about the country of northern Greece, there's a peninsula that kind of look like three fingers. And up through that peninsula, there is a huge amount of immigration, people moving from northern Africa up through Greece and into the other European Union countries for economic relocation primarily. But with that transition through Greece, that means that there are many women and children who are under-resourced, they're on the road, and in particular the children oftentimes either get left behind with their families or have no families and have been brought into the area for some of the very reasons we talked about today, trafficking. So the center has been very active in that region with community health training. They give us a list of the kinds of things that they would like their community health workers to be trained in. We've been doing a lot of screening for the children, working with vaccination programs and infection control in the children's hospitals. And that's been a very important effort for the Center for Global Women's Health. In addition, I continue my own work with the study of injury and the role of skin color after sexual assault and how skin color has an impact on the criminal justice system and the forensic evidence that's used as women pursue their their assailants through the criminal justice system. And this has an anchor in San Juan, Puerto Rico, as well as in Philadelphia. So we're in Greece, we're in San Juan. We have faculty members that are very active in Botswana and South Africa, among many regions of the world. So these projects are just two examples of how the Center for Global Women's Health is trying to further the health of women and children, particularly girls, around the world. And we're very lucky to count as many of you as sponsors in our mission to improve the health of women and girls. And I hope that as you move around after the lunch today, if you'd like to talk further about the center, I would be glad to give you some more information about it. Now we have an incredible opportunity to have with us a man who continues to have a direct impact on improvement of the California's communities and the health of its populations. It gives me great pleasure to introduce to you Dr. Robert Ross, President and CEO of the California Endowment, a health foundation established in 1996 to address the health needs of Californians. A proud Penn alum, Dr. Ross has an extensive background in health philanthropy as a public health executive and as a clinician. During his tenure at the California Endowment, the foundation has focused on the health needs of underserved Californians by championing the cause of health coverage for all children, reducing childhood obesity, strengthening the capacity of community health centers, improving health services for farm workers and ex-offender populations, and strengthening the pipeline for bringing racial and ethnic diversity to the health professions. Throughout his career, Dr. Ross has been an incredible advocate for the empowerment of women who, as family caregivers, and coordinators, played a unique role in shaping the health of their families. We are so glad to welcome Dr. Ross here today to share his observations, insights, and stories about how focusing on the lives and health of women can help us improve the lives and health of all. Dr. Ross.
Thank you for the introduction. Good afternoon, everyone. I noticed, I just want to say this to the Dean, that you have programs in San Juan, Puerto Rico, and in Greece, but you didn't invite me there to speak. Yeah, just made me deal with the 101 freeway traffic. And the other funny story is when I pulled up to to park my car at the valet here at the hotel, the young gentleman who was the parking valet asked me whether I was checking into the hotel, and I said no, I'm here for the Women's Health Conference. And he said, there's 300 very healthy women up there waiting for you. I was so glad my wife wasn't with me as he winked at me and said, oh boy. Thank you so much for having me. There's a lot of, sometimes you show up at an event and it's like that. Those of you that are old enough to remember that show, This Is Your Life, right? Penn people and Philly people and Mayor Rendell's wife is here, Marjorie, who was one of my favorite bosses ever. In fact, the boldest, the most courageous boss I've ever worked for was Mayor Rendell. San Diego people. So I'm going to string together some of those events in my life, and as I share with you, our career paths are shaped by our personal experiences and our relationships, and in my case, that is very definitely what landed me here at the California Endowment and informed and shaped and influenced all of the work that I do and that we do at the California Endowment, trying to improve the health and well-being of underserved, marginalized, ignored, overlooked, under-resourced populations and communities. And so I want to talk a little bit about that, that trajectory for me, and it certainly began during my time in West Philadelphia, my training at Penn, both as a pre-med student and then later in medical school, and then later as a pediatric resident at the Children's Hospital of Philadelphia, one of the great children's hospitals in the world. And what introduced me to the work that I find myself in now is what happened after I left Penn as a pediatric resident and began practicing pediatrics across the river from Philadelphia in Camden, New Jersey. And it is where I wanted to serve a low-income, underserved community. I spent time in Camden. I spent a little bit of time also serving in North Philadelphia at a clinic there. But what was interesting about my time in Camden, I arrived in Camden, New Jersey in 1983. And in 1984, the world changed if you were either living in or serving an underserved urban community, okay? And the world changed because of the introduction of crack cocaine and the infusion of crack cocaine and its influence into urban communities. And it was a game changer, and not a game changer in a good way. The impact of crack cocaine, I contend, from the 1980s still influences much of what happens and goes on in urban distress and low-income neighborhoods and communities. But what happened with the introduction of crack was an interesting phenomenon. And so the context here is this, Ivy League trained, Penn trained physician wanting to serve and heal a low-income, underserved community, and a giant wake-up call about what really produces and gets in the way of health, right? And so prior to 1984, poor people couldn't buy cocaine. Prior to 1984, prior to the invention of crack cocaine, cocaine was really it was kind of a white-collar, Wall Street, weekend, recreational users kind of drug, more or less. I'm generalizing here. But unless you had more than $100 of cash in your pocket, you just couldn't buy cocaine. There was no way for you to buy it, right? Until the invention of crack. And then the price point, the affordability point of cocaine dropped from $100 to as low as $5, right? And for those of you who remember your college or nursing school or med school pharmacology, cocaine is a very short-acting drug. It's very different than heroin or morphine, right? Heroin and morphine are metabolized more in the liver. It's a much slower metabolic process and processing, a pharmacological processing process. But cocaine is very short-acting with a flash moment of well-being and euphoria, and then you come down. Right? And so what happens when you introduce a $5 passport out of pain and hopelessness and poverty and misery into a community that's already on the ropes? Right? And so very quickly, within a year of my arrival at this community health center in Camden, New Jersey, and this was not just happening in Camden now, this was now playing out in North Philadelphia, in West Philadelphia, in Detroit, in Los Angeles, in Birmingham, Alabama, in St. Louis, in New York, all across the country, crack cocaine just swept through these urban communities like a scourge. And in every community, the footprint of the devastation that crack left behind was the same. From a public health and community health standpoint, and from the lens of myself practicing as a pediatrician in this community, all of a sudden, rapid increases in preterm deliveries and premature babies. You remember the word about the crack baby, which is the low birth weight baby born without much in the way of prenatal care. But in addition to that, you had concomitant increases in infant mortality, in domestic violence, in youth violence, in gang violence, in drug violence, in high school dropout rates, in tuberculosis, in sexually transmitted diseases as women began to sell themselves to support the habit, in felonies and robberies because men who were addicted were breaking into homes and stealing from their grandmothers and breaking into cars. That little thing that you have on your car key right now, the little thing that goes doot, 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 to open your car, that is a crack cocaine phenomenon. Because back in the 1980s, everyone was getting their car radio broken in, their car radio stolen, right? Some of you may remember, that are old enough to remember, in the 1980s, if you walk down the street in New York City or in Philadelphia or Los Angeles, some people actually put signs in their car that said, "No radio." Remember that? And that was also the invention of remember the detachable radio, the detachable car stereo? You could actually, well, that's because crack addicts were breaking into everybody's car. Right? So it was a sweeping phenomenon. And it just infiltrated into my practice. It infiltrated into my daily rounds, my pediatric rounds in the hospital, newborn baby rounds. The number of deliveries I was attending as a pediatrician, covering the delivery room for high-risk deliveries, went up. 600-gram babies, 550-gram babies. It really was quite a sight to see. And what I was getting was an in-service training on what we in public health now call the social determinants of health, the intersection of poverty and health and hopelessness, right? And that was a wake-up call for me. And I remember the moment, for those of us who have these kind of shifts in perspective and thinking, is kind of a burning bush moment. And a burning bush moment for me occurred in the week before Christmas in 1988, at the height of the crack cocaine epidemic around the country and also here in Camden, New Jersey. And I had, we all have families that we serve as health providers. And some families are more favored than others, right? I mean, just is sort of the way it works. And I had this particular family who was just one of my favorite families because of the mother. She was just this energetic, bright, poor but very optimistic kind of woman. She had 3 young kids. And one day they came in to visit. And the chart is in the rack outside the door, right? So you look at the chart before you walk in, so you know what you're getting ready to walk into. I looked at the chart and I realized the kids had missed several appointments and they were behind in their shots, which was not typical for this family. Okay, this was the kind of family, this is the kind of mother who shows up too much, right? The one that calls you at 3 o'clock in the morning and says, my little one has a runny nose and any fever, Velma? No. Is he vomiting? No. He just got a runny nose. I said, well, Velma, why don't you do the last time I told you when you called me with this, right? But you love her to death, right? So I walk in the office in the exam room. Mom's not there. Dad is there, whom I'd never met. 3 kids are there, behind on shots, and I start reading Dad a riot act. They're behind in their shots. They've missed appointments. What the heck is going on here? And by the way, where the hell is Velma? And so Dad, kind of pulls me outside, says, "Hey, Doc, can I talk to you for a minute?" And he pulls me out in the hallway and said, "Listen, man, Velma got hooked on that crack thing. And, I've been trying to get her in a program. I'm working 2 jobs now. And, just this past week, and I remember this story because of what he told me I'm about to tell you now, which was, in fact, it got so bad, I had all the kids' Christmas presents that we bought in the closet. And I checked the closet the other day and they're all gone. She took them to sell the Christmas presents for a habit, right? And so I had been seeing a lot of this month after month after month, but for some reason on that day, I had it. I just couldn't hear any more of these stories. I mean, I continued to practice there, but it was on that day that I decided that I've got to get upstream from this. Right? And I was very frustrated actually about my medical training. Nothing against Penn. Penn was a wonderful institution. But I realized that my medical training was about the biomedical aspects of health care. And I realized that I had been trained to function in a sickness system, not a community-based wellness system, right? And for some reason, it was just a moment for me that, I just one of those moments you go home, look in the mirror and say, wait a minute, what am I doing here? Okay? Talk to me, Lord. What do you want me to do now? Right? And so it took me a couple of years to make the shift. It's when I made the shift to leave the practice of pediatrics to go into public health. Ultimately came under the great leadership of Ed Rendell, who was the mayor of Philadelphia. He named me as public health commissioner, and then I began my career in public health. Left there, went to San Diego, spent 8 years in San Diego there, doing public health there. Now to California Endowment, and the focus of our work, I was able to sort of take in all of these lessons around the nexus of poverty and hopelessness and health and wellness, and think about what from the ground up, prevention-oriented, wellness-oriented community health could look like in many of these underserved communities. And so now we are in the second year of a 10-year, $1 billion statewide commitment to 14 communities, low-income communities, Camden-like, North Philadelphia-like communities, except here in California, to create better health environments, better healthy neighborhoods for young people. And I'm having the time of my life. It is, you understand this work, it's simultaneously exhilarating and messy, right, and frustrating, but it's great work. The next pivot point came, and I don't know if anyone's here from Kaiser Permanente. Any folks here from Kaiser? There's usually one, okay. Usually Kaiser people are everywhere. It's only one of you in here. So if you haven't had an opportunity to Google or read the Kaiser Permanente study called ACEs, Dr. Vince Felitti, the ACEs study is called the Adverse Childhood Events or Adverse Childhood Experiences study. And it's a study, it's one of those studies that, sometimes people do a study and on rare occasion, it tells you something you didn't know. In most cases, most of the studies affirm our intuition, right? But that's okay, you gotta have the data. And this is a study that both surprised me and affirmed my intuition and my suspicions. But here's what the study did. Kaiser looked at 17,000 or 18,000 of their Kaiser Permanente patients. So you have to understand, this is largely now a working class, middle class community or cohort of patients, right? And Dr. Felitti, who's a pediatrician, wanted to understand the relationship between exposure to childhood trauma and adversity and adult health. You with me? Okay. And what he did was he found a way to codify instances or episodes of childhood trauma. And so he surveyed all of these patients, all 17,000 of these patients. And he said, did you ever have a parent that was incarcerated? Did you lose a parent at an early age? Were you a victim of sexual abuse, of child abuse? Did you witness violence in the home? Did you have an alcoholic parent? All of these kinds of, the stuff that happens to families, right? And he compared the number of episodes of childhood trauma or adverse childhood experiences that these people answered yes to. And since he had all of their medical records, he compared that to their health status today. So most of these people in the study are now 35, 45, 55, 65 years old. He's asking them questions about what happened to them as kids. Are you with me? Okay. And so he comes up with chart after chart after chart that basically shows the greater the number of childhood adverse experiences you've had, the worse your health status as an adult, even 30, 40, and 50 years later, on a whole range of conditions. Childhood obesity, adult obesity, hypertension, depression, alcohol use, heart disease, on a whole range. In fact, if you listen to Dr. Felitti, he'll show you 20 or 30 charts where there's a relationship between exposure to childhood trauma and childhood adversity and the status of your health as an adult. Right? And so when I read this study, it reminded me of something that happened to me when I was running the Philadelphia Health Department. Because when I ran the Philadelphia Health Department, the same happened in San Diego, we were responsible for jail health and for running alcohol and drug treatment programs. And occasionally I would visit the programs just to see how they were doing and meet with either the jail inmates or the people in the drug and alcohol treatment programs. And for those of you that have been in this business, if you've done anything with women in alcohol and drug treatment programs or women in prison, if you get in a room of 15 women that are in prison, or you get in a room with 15 women that are in alcohol and drug treatment program, and you ask them how many of you were sexually abused, you will see a whole bunch of hands go up. Okay? Maybe not 100%, but easily 80%. Easily. And I remembered at the time seeing that, and I said to myself, what the hell is this about? What is this? Even then, why is nobody talking about this? Okay? And so seeing that a significant percentage of Kaiser Permanente patients, women, admitted to being sexually abused, and that affected their health 30 years later. And the Kaiser Permanente population is a relatively well-adjusted, relatively stable population, right? It makes you wonder, well, wait a minute, what's going on what's going on with populations of communities from, people from Richmond and South Central Los Angeles and North Camden and North Philly and Detroit, and wait a minute, what's going on here, right? And so the Vince Felitti and Kaiser Permanente Adverse Childhood Events Experiences study blows up an adage that our grandparents told us many years at the dinner table, which is, well, time heals all wounds. Excuse my language, but that turns out to be bullshit. Okay? Maybe time heals some wounds. And so now we have an open door in a very expensive, the most expensive medical system on the planet by twofold. Okay? And what's driving our costs are the burden of chronic disease, from obesity to diabetes to high blood pressure to depression, to fill in the blank. And essentially what Dr. Felitti has unlocked is, wait a minute, what's happening to all these people? Not all of them, but many of them, a significant proportion. And by the way, what do these data and what does this study mean? What implications does it have for how we think and rethink health and healthcare in this country? So I've been on this kick lately about trauma and childhood adverse experiences and health status for the individual, but also health status in the community. And I've been visiting places around the country that do work with young people. I visited one program in Harlem called Brotherhood Sister Soul that does a lot of work with at-risk young people in Harlem. And we were in a conversation about trauma and young people. And this particular program uses the creative arts and artistic expression. My good friend Deborah Marrow's here from the Getty, and Deborah, this is something that I mentioned. This how so many programs that work effectively with young people in these communities around wellness use the arts and creative expression to get young people to tell their story, right? So I want to tell you one story. And this was in a book that was published by this particular youth program, and they published poems by the young people who came to the program. Right? So this is a poem. It's a little bit lengthy, but bear with me. And the language is a little salty, but I don't want to compromise her message by cleaning it up. Okay? So you can forgive me for that. And the title of the poem is called Daddy Keeps. Daddy keeps. Daddy keeps having fights with my body and daring me to tell mommy. He covers the bruises with my t-shirts and the ones inside with pocket change. He keeps saying that it won't happen if I just act my age. Daddy keeps abusing me, the scars keep adding up. Mommy keeps ignoring me like she don't give a fuck. She has to hear the screams that sing like octaves on a scale. I've told that lie 1,000 times, she still can't believe it's the bunk bed rail. Mommy thinks infidelities are near and she thinks it's her best friend, TT Andy. I like when she's around because only then we feel like family. Mommy always says at home, though, I dare that bitch to mess with my man. I wish she would. I want her to. But never did she stop to think her man's cheating with her 10-year-old daughter, who has brought her to the crime scene only 10,000 times before, the countless cries and the bloody sheets piling high on the laundry room floor. The family's DNA exposed through dried cum stains on Barbie's face. Go-Go Power Ranger sheets, the battleground for his adultery. Daddy keeps saying that my private parts are not just so to him. He says that it's okay to touch because he helped make them. Mommy says that it's not right. Mommy says that it's not right to, but I hate him. Daddy keeps peeking at me from behind the TV, winking because he's sworn me to secrecy. No one knows the games we play at our midnight slumber parties. Daddy keeps saying that it won't hurt as much if I just cooperate. And if I can't learn to keep it down from my mouth, he'll slap the taste. I wrote in my Dora diary that I wish God would take my life from me. 5th grade just ain't the same since I can't share stories of pain. Slide burns and knee scrapes just don't compare to daddy rape. The wounds I'm left with won't heal with peroxide and Band-Aids. Scotch tape can't put back together the things that daddy takes. Innocence, a new vocabulary word I'm just learning now how to spell, and a gift of mine stolen. The school's new social workers hoping something's wrong with me so they can get a raise in their salaries. But my silence is golden, like the rings and things that daddy keeps leaving on my dresser. I guess trying to make up for the life he's made a mess of. But for the rest of it, I'll have a stained memory with all the fucked up things daddy keeps doing to me. $17. So I read this on a flight back from New York to LA, and I wept like I'm weeping now. And the person next to me said, "Man, you all right?" Yeah, man, I'm all right. Now, the good news to this story is that because I had to call the executive director of the program when I landed, I said, "Man, what happened to this girl?" Okay, her name is Cheyenne. He said, "Oh, she's doing fine now. You know, we got her into counseling, we got her into a program, and she's now a youth worker with our program." Okay? And so the beauty of this is that because this program was able to create a safe space for this young woman to share her story, right? And she's now engaging with other young people and getting the kind of counseling and training that she needs. And she's now a worker. She's now a youth worker working with other young people. The beauty is, if this shows up in her space, she's not going to miss it. Right? She won't miss it. So in a sense, it is an asset to have a woman like this with this kind of experience somewhere in the neighborhood of our healthcare system. Because the question I have about Cheyenne, these women and these girls show up in our system, but they don't show up like this, right? You with me? They show up with, I got headaches. This girl's not coming to class. Chronic stomach pain. They show up in our emergency rooms. They show up in our school-based clinics. They show up in our ambulatory clinics. And the question is that Dr. Felidi's research poses is, do we have a healthcare system smart enough to pick this up and not wait for Cheyenne to be an IV drug injecting user that ends up at Graterford Prison? That's the challenge of the health system. How do we create and re-engineer and rethink what we do? Because young people are being exposed to this level of trauma and adversity. Right? And so I've been waiting for this conference to download this. Because the only cohort of leaders that are going to fix this are women. Okay? When child abuse was a public health issue stuck in the closet, who brought it out? Women. When domestic violence was an issue that no one could talk about, stuck in the closet, who brought it out? Women. When drinking and driving was just something that, oh, well, it happens, who brought it out? Who made it a public policy issue? Women. Here's the next one. Okay? The issue of sexual abuse and human trafficking, whether internationally or domestically, is a significant public health issue, and I can't give you data and statistics on how common it is because we don't have it. We can give you guesses. This is the kind of stuff that's too squirmy for people to take up and deal with. It's too uncomfortable. Makes you squirm in your seat, right? Rather talk about something a little more comfortable, right? But those of you that are my age and older, you remember when people could not even talk about having cancer. For my generation, the older generation, for some reason, and I don't know why to this day, if someone had cancer, it was a secret. It was like they did something that brought on that shame. He's got cancer, you know. That's what it was like back then. Today, it is fundamentally different, right? It is now a badge of honor. And it's a good thing from a public policy and education perspective. So I believe this is the next dragon to slay in public health. Right? And I do want to underscore the dean's comments, her threefold approach on this. And one of them is going to be, obviously you need data, but in addition to the data, we're going to need voice, and we're going to need advocacy, and we're going to need to make some people feel uncomfortable with the lack of action on this. And we'll be glad to be your partner on it. Thank you.
We promised you'll be done by 2, so I think we're going to come to a close, and Dr. Ross will be here if any of you would like to come up and ask him questions. I just want to take 1 minute to thank you all for devoting your day to us. I can't thank you enough. And to everybody who participated in making this happen, I thank you from the bottom of my heart. You have all become part of an ongoing conversation about urban women's health, and you now have the opportunity to continue to be involved in this movement. I encourage you to follow the work of the Center for Global Women's Health on Facebook, on Twitter, on our website, www.nursing.upenn.edu/healthywomen. Stay connected. I think I can best wrap up today by quoting Lynn Summers, the director of the new Center for Global Women's Health, who you heard from earlier. As the health of women goes, so goes the health of the world. Thank you for coming.